Working with suicidality in patients. Now, Beck talks about this within his book, Cognitive Therapy for Depression, and I really encourage you to go and have a read of it, as well as look at other risk management, risk assessment and management processes, either locally as well as sort of centrally, looking at NICE guidance and so forth. So I wanted to talk about this because I think it's really important. You are going to come across patients when they have a depression who are suicidal, who have these thoughts. And Beck highlights that actually some therapists still believe the myth that actually asking a patient about suicidal ideas may put the idea into their head or make the idea more acceptable if they'd already thought about it. But actually, encouraging a patient to talk about their suicidal ideas generally helps them to view them a bit more objectively and provides necessary information kind of for therapeutic intervention. And it does offer some degree of relief. So when assessing a patient with suicidal thoughts, there are several things that I like to consider. And you can look into the 5 Ps, which I'd sort of really encourage you to do alongside this. But specifically, these are things I like to consider. So I always ask when a patient is thinking about suicide is what the content is of their thoughts, of their suicidal thoughts. Specifically, you know, how specific are their thoughts as well? So is it, I wish I wasn't here anymore, which feels a bit more passive compared to actually, you know, I want to get a noose and hang myself. You know, that's a really specific thought. And obviously quite concerning as well. Now, look, all these thoughts are concerning. I'm not diminishing kind of the severity of any of these. The other thing I like to consider is how they might act. So have they given this any thought? Because that's obviously one step further. You know, have they thought about how they might do it, or when they might do it? Intentionality is something that's, you know, I think most people agree is really good to kind of understand how much intent does the person have on acting on these thoughts. And you can ask them to rate this from 0 to 10, 10 being that they absolutely intend to act on these thoughts, and 0 being that they don't. I like to ask if someone has had thoughts, if they have any plans on doing this, you know, suicide plans for now, but also future plans. Do they have positive future plans kind of set in for the future? And this can kind of give you, again, another degree of the severity, that how much you should be concerned and what have you. I always ask whether they've taken any preparations. Have they written a note, or do they have a will? And sometimes it's about kind of checking in more subtle cues on them saying, oh, you know, I've just written a will, and maybe it's about you inquiring a bit more about that. It's really important to understand any precipitating factors, so triggers for their suicidal thinking on a day-to-day basis, but just more generally as well. Time frames, so when the person is thinking of doing it, if they do have plans. And I suppose that the 2 other things I think are really important is history, about whether they've done it before, the history specifically of any impulsive kind of suicide attempts as well, or any risk that's conditional. So risk, so for example, I'm okay now, but if my dog dies, then that will be the last straw. And of course, if risk is ever conditional, it's kind of getting a sense of how likely that is. So perhaps their dog is very, very old or very unwell, and that would give us some real kind of serious kind of risk warning signs. And it's also really, really useful to understand those protective factors and what is stopping them from sort of taking any action at the moment. What has stopped them before? What resilience features have they had? You know, what helps them call for help? What would help them or make them more likely to call for help? So it's just really getting into the head of that person and understanding how you might be able to help them. Now, there are other clues such as that kind of being secretive, or kind of those sudden decisions to make, as I said, make a will, or verbal statements like, you know, I just want to end it all, or maybe even more subtle, I just can't take it anymore. Now, they should all alert you that you need to ask more questions. They might sign off with saying something like, "Thank you for trying to help me." Now, Beck highlights that research shows 40% of completed suicides had visited a medical or psychiatric services in the week before their suicidal action. So this is a really, really big deal. It's really something for you to be aware of and mindful of. So when concerns arise, what do? You need to, I think basic risk management training is essential. If you can seek any kind of risk management training, then that's great. But the first port of call should always be to see if they can access any help or know where to go or who to call. And that is really the very first thing. Specialist services with risk assessment and management skills are absolutely the first port of call, and this would take precedence over any therapy. So this is in NICE guidance. So obviously get them linked in with specialist services. Just as important and basic is making sure they have a viable support system. So you should follow those confidentiality agreements that are in line with the legislation in your country, which will help you consider whether you're able to contact family or statutory services without consent. But the best thing to do is ask the family, ask for consent to speak with family about these thoughts. Of course, that is unless you think it's going to put a person at more risk of acting on suicidal thoughts. For example, if they have a really volatile relationship. Now, in therapy, if I ever had a strong concern over a safety of a patient, then I would usually pause treatment really. And if you're operating in England, I'd link them in with an NHS crisis service and ask them to return once they'd stabilised. However, if it is safe to continue, i.e. risk is at a threshold that is manageable, i.e. the patient can keep themselves safe, there's very low intent, and they feel okay to continue, they have some resilience, some really strong protective factors, and some they can manage kind of how they feel to engage while keeping themselves safe, then I would seek supervision and really seek supervision with a view to continuing, and it's in this instance that I would employ the following techniques. Okay, so I would normally now, if a patient were to be thinking like this, I might explore the motive for suicide. For example, if a patient were thinking about escaping from life versus it being about bringing about interpersonal change, it might So if it were to escape life, I suppose I would focus on, the focus would be on their hopelessness and their lack of positive expectations. And if these are realistic, such as things like poverty or medical conditions, social isolations, then I'd make sure that we got some appropriate social intervention as the first port of call. And as a therapist, it's okay to understand that you may not be the most well positioned to provide that. So you might seek more help from another sort of source of support in your community. But if these thoughts are based on kind of distorted or pathological ways of viewing the world, then Beck says that the therapist should focus on the misconception and the irrational belief system. Now, if in the third condition it was to bring about interpersonal change, it may be worth exploring the motives. So was the suicide attempt promoted by, for example, the desire for someone's love and affection? So it's really important to understand what it is specifically that makes the patient feel this way in order to understand, so that you can fully empathise and communicate to the patient that they feel understood. So it's really important not to guess anyone's motives, and to really explore these in an open way. So the next step is about tipping the balance against suicide. So Beck talks about this in his book. He says that initially it's about the therapist playing for time until that danger period about suicide has passed. In real terms, it's about looking for reasons to postpone suicide, stick it out, keep going, possibly see where therapy is going so you can promote some hope. And it also includes looking at the patient's reasons for dying. So it's really important not to dismiss these and exercise with extreme empathy. Above all, avoid using any ploys such as saying flippantly, if you want to go kill yourself, go ahead and do it. You do not say that. It's about kind of, I suppose, it's a dangerous game. It's just got to stay really empathic and really open and understanding. Then it's about exploring the reasons for living. Now, if they're really struggling, you could even consider reasons for living that were valid in the past, and then consider whether these are still valid now. So with someone with depression, these are naturally ignored usually, or their value is kind of discounted. But Beck tells us it's really important not to suggest these to a patient. If a patient senses you're trying to talk them out of suicide, then they may in fact argue back, as we know. So when dealing with hopelessness, there may be thoughts like, there is no point to living, I have nothing to look forward to, I just can't stand life, I will never be happy. I want to escape this feeling of being miserable, or I am a burden to my family and they're better off without me. So Beck has developed a hopelessness scale to help identify this, and you may want to check this out, so have a look at that. But really, we want to convey, as cognitive therapists, there's an alternative interpretation of life situations that is less dire, and there are other choices than suicide. So in this case, I would explore those logical inconsistencies in the belief system. For example, someone might say, I can't live without my partner who's been having an affair. I'll be nothing without them. And I suppose it's questioning, are you always happy with them? Well, no. Why? Because we argue an awful lot. Well, how can you be nothing as well? What does that look like? So you can't be something. And How have you been living for the last few years? Well, he's been living away an awful lot. Okay, well, is that really living with him then? Well, actually, no, I've been living on my own quite a bit. And even before you met this person, how did you live? So it's about questioning all of those things, using that Socratic dialogue. And then finally, problem solving. So I'd go and have a look at problem solving, but it might be problem solving a practical issue that's really involved in the depression. I don't know, failing an exam, not getting into the university of your choice. It might be about money or next steps in your educational journey. So finding an alternative way to learn and cope with reactions from family about this might be a source of problem solving, or something helpful to role play to give a patient more confidence in doing this. Now look, there are loads more strategies outlined by Beck that I would encourage you to go and find. Risk might fluctuate during a treatment, so it's really important for you to be aware of this and take action and flex your style based on your patient need. Thank you for listening, and I hope you can take care of yourselves now after such a really hard topic, really. So I hope you can practice some self-care now, perhaps later or perhaps before the next video. Thank you.